Hello, Gold viewers from around the world. I'm Kristen Schwartz, licensed midwife and MC here at Gold. And today we're getting ready for our Gold Tongue Tie Symposium of 2025. And with me here is my special guest, Reka Morvay. Hi, Reka. It's so nice to have you here with us today.
Hi, thank you for having me. I'm glad to be here.
You have a very wonderful presentation planned for us, navigating tongue tie in the hospital setting, the IBCLC's role in assessment, communication, and support. Very important. But before we go into that, you are, of course, an IBCLC and you are in the hospital. So tell us a little bit about your background and your, professional journey.
I'm an IBCLC, like you said. My background is actually in psychology. And even though currently I'm practicing in Southern California in Los Angeles, I did my training and a fair bit of my work as an IBCLC in Hungary. And I've been in the States since 2014, and I've been working in a hospital environment since, oh my goodness, I think it was 2017.
Quite a while now.
Yes,
So
yes, almost 10 years.
time flies. Well, you have the wonderful background of psychology and IBCLC, the wonderful, beautiful combination because we know so much is wrapped up also in that, right? When clients come to you with problems feeding their little ones, it's always so difficult and a lot of emotions go into that as well. So you have that wonderful background that you can, serve your clients and families with. Now let's talk about the hospital. It's quite, after birth, there's very little time really, right? There's so much going on.
Yes.
For example, first, the family often is very prepared nowadays for the birth. They know they read the books, they did the classes and all that, and every focus was on birth. And now baby is here, and now there is an issue with breastfeeding and then possibly a tongue tie. So but you are in this hospital there,
Mhm.
and it's busy. You don't maybe have as much time as somebody in private practice. Maybe they what.
Absolutely.
So it is a completely different environment. Talk to me a little bit about that.
Yeah. I worked in outpatient and in private practice for the majority of my career. And it's the last 8 or so years that I've been inpatient in a hospital, and it is very, very different. Obviously, the setting is very different, the circumstances are different, the baby's age is very different. So, unless you work with clients through a midwife or a birth center as an IBCLC, you are unlikely to see babies as early as a hospital IBCLC. So we see the babies for their first 2 days of life, 3 days of life. And so that means that our focus is on this very, very narrow window of opportunity during which we get to interact with the parents, do our assessments, attempt to see whether their trajectory is, heading in the right direction. That is part of the challenge in an American healthcare system is how fragmented the care is.
Mhm.
Even within the hospital, it's very fragmented, but often families, for example, they discharge after 36 hours. That's a day and a half during which
Mhm.
baby has to get all their testing done. Mom has to get her testing done. They have to take care of all the administrative tasks like the birth registration. And it just leads to this environment that is extremely disruptive
Mm.
to any sort of calm rest or bonding with the
Mm.
baby, because there's so many interruptions and there's so little time to get everything done. And so I see that as one of the biggest challenges of working
Mm.
in a hospital in the United States is how short stays are and how many procedures and tests and things they try to cram into that short stay. But
Mhm.
then we know that after they discharge, they are often lost to follow up. And that is a very,
Absolutely.
again, particularly American problem to have, because in most other countries that I'm aware of, definitely in Hungary, there would be organized within the healthcare system handoff and follow up with families after they leave the hospital. Their care is transferred to their local pediatrician, their local health visitor who is a nurse slash social worker who would make house calls and check in with the family, make sure that everybody's safe. We do not have anything like that in the United States. The closest thing that comes to it is if a family hires a doula or a newborn care specialist or a postpartum nanny, and otherwise, once they leave the hospital, it's their responsibility to get themselves to a healthcare provider, and that is how so many families are lost to follow-up, and that is a huge challenge because as we all well know, the first 2 or 3 days of breastfeeding are not indicative of how things will continue to go, and the babies need follow-up, and the moms need follow-up, and it is something that as hospital IBCLCs, we are extremely aware of that kind of responsibility that, we get something done now and we give the families the resources they need and the plan of care that will keep them safe in the now because this is our one and only chance to do it.
Right. So how do you navigate that? How do you navigate that? Do you have also maybe a list of resources available for them when they go home? Are you able to follow up with them? How do you
Absolutely.
navigate this short stay
So
and all that?
we do not have the opportunity to follow up with them unless they call us back. So at my hospital in particular, um, our team is inpatient. We have a separate team for inpatient, so families on the postpartum unit, and we have a separate team in the NICU. Right there, you have some fragmentation of care
Yeah.
because it's a different team helping while baby's up in the NICU and a different team helping when baby comes down to postpartum. We also do have an outpatient clinic, but again, that is completely separate from our inpatient team.
Mm.
And so some of the ways that we sort of bridge these gaps is just really extremely detailed documentation. The
Mhm.
documentation has to be very thorough and complete because we are relying on our colleagues on the next shift or on a different unit to be able to go look at our documentation to figure out what has been done, why did we gave the recommendations that we gave, and so that's how we try to handle handoff.
Mhm.
But again, in Southern California, the area of service of this hospital is so huge. We have, I think, about 7,000 births a year. So this is a huge hospital system. And a lot of people come from pretty far away. And for those not familiar with Los Angeles, this is the area where the term road rage originates from because traffic is so bad. So even though families will come in for the delivery, often they live too far away and they will not
Mm.
come back for,
Got
their follow-up
it.
visits. So
Yeah.
that means they have to find something that is local to them that is more accessible than our hospital. To answer your question, though, yes, our hospital, even though we are not a baby-friendly hospital, we are working towards the hospital model hospital policy. So we do follow the 10 steps to the best of our ability, and we do give outpatient resources. There's a whole handout for them that
Mm.
includes, a message line for them where they can communicate with us. It includes our outpatient clinic. It includes other databases and websites online where they can reach out and find local lactation consultants and clinics where they can go and get lactation care.
That's wonderful. You mentioned fragmented care, fragmented, all these different, providers or, so your documentation has to be very clear. So the one on the next unit or somebody else who, who takes over is able to really work with that and understand it. Well, how do you navigate situations where maybe another healthcare provider, physician, maybe a nurse, whoever that might be, may be resistant to discussing tongue tie or might be dismissive of your input with regards to that?
So, because we're in a hospital, the doctor's word trumps the lactation consultant. The final decision rests with the physician. And particularly at our hospital, we do have a good working relationship with our physicians, many of whom have taken lactation training, some of whom are working on their IBCLCs or their breastfeeding medicine credentials. So we're lucky in that sense that our in-house pediatricians are very much on board with the lactation team, and we have a good working relationship with them. They often will ask for our input. They will, see something and ask lactation to come in and assess and see if it is causing a problem for breastfeeding purposes. But then again, fragmentation of care, it's not the pediatrician who actually performs the procedure or evaluates the baby for the frenotomy procedure, it's an ENT. And so the process is that if I am asked by a pediatrician, and the way that they ask is they put an order into our system because, again, I might never see that pediatrician. They might, make that call on a previous shift. They put in an order into the system that pops up on our work list for the lactation team. And I see that the reason for the order was that the physician noted a visible lingual frenulum and is asking for a tongue tie assessment. So then I would go in, I would assess the baby, I would assess the breastfeeding session. We use the Hazel Baker tool within the lactation team. A lot of the physicians use the Tabby tool. Um, and so again, we're not looking at the same things sometimes. But if I think that the restriction is interfering with breastfeeding in the moment, then I communicate that to the bedside nurse. The bedside nurse lets the pediatrician know, and the pediatrician has to put in an order for the ENT consult. That's when the ENT comes by, assesses the baby for whether they're a good candidate for a frenotomy, because sometimes they are not, and makes, they also chart and document and makes a recommendation to the family, but it's still up to them whether they want to go through with the procedure. So it is a multi-step process. And again, I often do not interact with either the pediatrician or the ENT in person. I
Mhm.
would then be called back into the room to reassess the baby to see if they need any further help with positioning and latching or to make things more comfortable. But there's very little face-to-face interaction with the other providers.
Interesting. Well, thank you for sharing that, how things work in your hospital there. Now, before I let you go, Reka, tell us a little bit what you are hoping our viewers will take away from your presentation specifically.
So, as an IBCLC myself and somebody who has worked inpatient and outpatient, so in private practice and in a hospital setting, I completely understand my colleagues' frustration
Mm.
with the current state of understanding or assessments or treatment options. There's so much variability and there is so much confusion. And for the patient, it's really, really tough when they have multiple people who are supposed to be experts coming in and telling them different things. And I've experienced this from both sides. As an outpatient LC, I would be like, how could the hospital IBCLC make this decision or make this recommendation? What were they thinking? And then as an inpatient IBCLC, I see the constraints that we're working with and that we are trying to get these families the best prepared that we possibly can with the limited amount of time that we have to interact with them. And sometimes that means, they need further support. We are not able to continue their support. So all we can do is give them the anticipatory guidance and give them the resources for where they can find further support. The takeaway that I want is for better understanding, I guess, between inpatient and outpatient or physician and lactation consultant, so that we can give each other sort of the mutual benefit of the doubt that they gave the best recommendation that they could with the information and the resources that they had. But there is just a lot of uncertainty and a lot of obstacles in the way of really coordinating care in the way that would serve families the best.
Well, Rika, thank you so much for being here with me today, talking about this very important topic of your presentation, navigating tongue tie in the hospital setting, the IBCLC's role in assessment, communication, and support. Thank you so much for being here today with me.
Thank you very much. I appreciate it.
And some information now for our viewers. This part is, of course, part of our Gold Tongue Tie Symposium 2025. We get started with our symposium. It's just around the corner. September 15th, we have Dr. Agarwal give a keynote presentation. This keynote presentation is open and at access for everyone, free of charge. So make sure you find out more about Rika's presentation and all the other presentations in the symposium, as well as the keynote presentation. And we invite you to go to goldtonguetie.com to reserve your seat. And I hope to see everyone at the symposium. Thank you so much for watching. Bye bye, everyone.